Good morning and evening, wherever you are in the world, and welcome to the Bonnie J. Addario Lung Cancer Living Room and Patient Educational Series. I'm Bonnie, and thank you for joining us. From our living room to yours, we are all living with lung cancer, and our goal is to bring hope into your home. Empowered patients live longer, and our message is simple. We want you to live.
Hi everybody, welcome to January's Living Room. I want to say hello to everybody signing in online. I know I did a big, huge, obnoxious blast or two about this meeting, making sure that we got as many people out there that we could to sign in tonight and hear what Dr. Camidge has to say. So we're going to start with original, like we normally do with our Around the Room. Anybody online who wants to make a quick shout out and an introduction so that Dr. Camidge knows kind of his audience and who he's talking to. This, by the way, is Dr. Ross Camidge, MD, PhD from University of Colorado, Denver.
You call me Ross, you don't have to call me Dr. Camidge.
I know, you don't.
Unless you really want to, I mean, it's up to you.
So we're going to do things a little bit different tonight. We're not going to do a presentation as per Ross. We decided to do a more relaxed sort of just Q&A. Who are you? Why are you here? Why do you do what you do? And what's on the horizon? So we'll start with the Around the Room. We're going to keep it short, obviously, because there's a ton of people in here and for whoever online. So just your name, when you were diagnosed, what you were diagnosed with, what type, and how you're doing, any updates, anything like that. You want to start, Liz? No? Yes?
Thank you. Hello, welcome. My name is Elizabeth LaCasia. I was diagnosed approximately 2007 with bronchioalveolar carcinoma. I had a portion of my lung taken out, and then it came back all throughout my lungs about 12 months later. I went on several clinical trials, and the first combination I had was Avastin, Gemzar, carboplatin, was on that and progressed, and then went on to Alimta and Tarceva, and then I went off of the Alimta because I was having issues with my kidneys. But I'm now, it's very stable. I responded extremely well, and I'm on my 54th cycle of Tarceva.
Wow.
So, and I am a very strong advocate of molecular and genetic testing, so I just thought I'd say a shout out for that. Welcome.
Thank you.
I'm Wells Whitney. I'm a co-founder of this foundation with Bonnie and her tribe. I was diagnosed in 1998 with stage 4 lung cancer, non-small cell BAC. Went through a lot of chemo, had a lobectomy, had more chemo, and I've been on Aressa now for 11 or 12 years. I have no idea if it's doing me any good, but it's not doing me any harm, and I'm still alive. And I have a few questions for Ross later on how this whole field is moving in terms of molecular testing, targeted therapies, and what someone like me should be doing about this and how to go forward. Okay, thank you.
Thanks, Wells. I'm Scott Santarella, the president of the Bonnie J. Addario Lung Cancer Foundation. Huge fan of Ross's. And just a shout out to Wells, who oversees our research review process through our scientific advisory board. And we made some decisions late last week on about $1 million worth of funding of some pretty novel and exciting research that we think is going to impact patients' lives. So we're excited about that, and Wells takes on the lead of that, so we thank Wells so much for his volunteer efforts there.
I'm Esty Caldwell, and I was diagnosed in 2000. oh God, 2002 actually. And stage 1, bronchoalveolar. And I had surgery the top and center lobe. And I didn't have chemo or radiation. That's it.
And you told me about your daughter as well. She had lung cancer?
My daughter, yeah. She had, we had cancer at the same time.
Okay.
It's just that I didn't tell her because she was dying. And she was in stage 4 because they found it too late. And they treated her for colds, flus, and allergies before they even gave her an x-ray. And Golden, Colorado.
They have a mic, SD. Thank you.
I'm Laurel Dubb, and as usual, I have my spokesman and assistant, and thank goodness he's around. Husband, tell about what's doing me in or whatever.
I'm the spokesman for her husband. I've forgotten which now. But in any event, Laurel was diagnosed with 4th stage non-small cell lung cancer in about September or October of 2011. She's been through carboplatin and Alimta, which did some good. And then she went on Tarceva, which did no good whatsoever from day one. And then she went on a test study at Stanford, which was Tarceva plus dobutamine, or whatever it was. Something that was an FGFR inhibitor. Okay. And right now we've just made contact with Dr. Gandara, saw him last Wednesday, and we're waiting for him to get back to us. He wants to do a new biopsy since she does have the EGFR mutation, or her cancer does, but the Tarceva was completely ineffective, so he thinks that it may have mutated away from that and wants to find out what might be useful. Okay. And we're signed up for potentially going on a study. She's signed up for potentially going on a study. So we'll figure it out when we talk to him as to whether or not she can take regular chemotherapy while we're waiting for the biopsy.
I'm Chris. I'm Jennifer's little helper.
And he'll speak for me.
Oh, I'll speak for you. Jennifer was diagnosed with stage 4 lung cancer in 2011, October?
2010.
2010?
Yeah.
Just after the birth of our son. She was EGFR positive, went on Tarceva, that was effective for 9 months. The first indication we had that it wasn't working is Jennifer was not following the instructions of her doctor, and she was not taking doxycycline. And her doctor was rather concerned that she didn't have any blemishes anymore on her face. So that was kind of the initial indicator that things were going south. We went to Dr. Gandara in UC Davis, and he entered us for a couple of studies and signed us up for a biopsy. So Jennifer had a VATS procedure, a resection, August last year. We were looking or thinking maybe T790M positive, but she was not. So there wasn't a mutation, but there was an indication that she was MET positive. So we've been on a frantic search for some magic combination of drugs. It's a little frustrating because most of the drugs in this field are preclinical, and all the exciting studies seem to be not available to us anymore. So we're really happy to see Dr. Camidge here. Jennifer's currently on and Taxol, carboplatin and Taxol. Jennifer also recently had whole brain radiation to attempt to kill off some lesions. It wasn't completely successful. She's just had a follow-up with some cyberknife, also on her spine, where she has some active area.
Stable.
It seems to be stable.
Thank you. Hello, I'm Mary Basso, and I was diagnosed in October of 2010 with stage 4 non-small cell lung cancer. And I had 13 rounds of carboplatin, Alimta, and Avastin. And then I went off it because I started having kidney damage. And in November of 2011, I had the radiation, the cyberknife on my lung tumor and on my spine. And then
They
I went.
placed the fiducial markers, yeah? Isn't that what you had?
Yeah, I had fiducial markers.
Yeah.
That's the cyberknife.
Yeah.
The robot tracks it by these little metal pellets.
Right.
You know it better than I do. You went through it.
And then I didn't have to have any treatment at all until this past October, and I started on Tarceva. And that's what I'm on, and I'm hoping it's working.
I'm Mary's helper, and she doesn't need any help speaking ever.
Oh, boy.
I'm Elaine Gray, and I have stage 4 lung cancer, BAC. I know how to say that, but I don't know the other name. But anyway, I've been on a little respite. Dr. Dormady is my oncologist, wonderful Dr. Dormady. And I got very sick because I had so much chemo. I've been on chemo for 4.5 years of some type. You name it, I've been on it. And I am now, or was on Avastin and Taxotere, very low dosage, and understanding that from Dr. Dormady that BAC, my type in particular, is very slow growing. And all my signs were so good last time. All the blood draws have been just wonderful. And I just was sick. I had to go to the hospital, but everything looked good. I had shrinkage in the tumors on the right side, and here I am throwing up and can't eat, But anyway, that's all over with, and I probably will start chemo again the first week in February. I'm feeling so much better, and I don't even know I have cancer. And, so it's good to feel good. Thank you.
I'm Penelope, and my mom was diagnosed in February of last year, 2012, stage 4 non-small cell, non-smoker, and she had pleural effusion. She had a pleural decyst that went really well. She recovered really well from that. She started on oral Tarceva and responded really well for the first several months to that. And then that stopped working, and there was some growth in a couple locations. Spots got larger. So she, the end of November, started on some IV chemo. And she got a scan a couple weeks ago, and it was good. Things were shrinking. And her blood test last week was really good. All her levels look stable. So in about 2 more weeks, she gets another scan. She's had 4 rounds of the chemo now. So we'll see what happens after this next scan.
Hi, I'm Tina, and I was diagnosed with non-small cell adenocarcinoma November of 2010. I did a regimen of chemo and radiation, and after a clean scan, after that was finished, I started on Tarceva, and I've been on Tarceva for almost 1.5 years now, and scans have been no evidence of active disease. So far so good. I have a scan next month, though. You know how that is.
It's called, what's this called? Scanxiety, right? Yeah. But anyway, I'm her husband, and she's been a saint. She's been unbelievable.
Do you want to? Oh, we'll go this way, then we'll come back around. That's fine.
Hi, I'm Dave Palomares, and I was diagnosed with mesothelioma about 4 years ago. It would have been January 2009. I went to UC San Francisco for second opinion, where they put together a treatment protocol for me and started it right away, consisting of an extrapleural pneumonectomy and chemotherapy, cisplatin, with Alimta and radiation. And since then, I've been getting CT scans it started out at 6 months intervals. Now I'm on a yearly basis, and so far, all my scans are clean.
Hi, my name is Christy Chappelle, and I was diagnosed with adenocarcinoma, non-small cell, in late 2009. So I'm starting my 4th year living with cancer, and stage 4. So they hit me with everything but the kitchen sink: the carboplatin, Avastin, Taxol, Iridia, because it was also had spread to the bones. And so that worked for a while, and in the meantime, I was tested for, the big 3, EGFR, the ALK mutation, and KRAS, and I'm negative for all of those. But I did go on Tarceva for a while, and couldn't tolerate the 150 milligram dosage. The rash almost did me in.
Okay.
But I did on the 100, and I was a candidate for a while for a clinical trial at UC Davis, a medication that would boost the effectiveness of Tarceva, but I couldn't get my labs to get into the parameters that were needed for the test. So unfortunately, I missed out on that.
Do you know which labs were out of whack?
The creatinine.
Okay.
My kidney function was, I didn't have happy kidneys.
Okay.
And it's much better now, so the potential for future clinical trials, I think, is there. So then when the Tarceva stopped working, which it did, my doctor had me try Alimta, but that, I could not tolerate that, and which is unusual, as I understand. Most people do well with Alimta, but for whatever reason, it made me very sick. And I've been very happily on Taxotere for almost a year, and it was working well. My labs were wonderful. I'm feeling wonderful, but I just had a PET scan on Monday, and it shows that there's some activity again, and in the pleura of the front part of one of my lungs, so that the doctor feels that it's time to switch up medication. And so we're making a decision whether we try Alimta again or go to gemcitabine. So Danielle's going to help me tomorrow work through some ideas and some options. I'm at a crossroads, but I've been feeling good and living my life, and I told her I'm making a trip to Monterey this weekend, and so let's not start treatment until I get back from Monterey. I'm going to live my life.
Sounds good.
So that's where things are for me. So thank you.
Yeah. Chris, you do. Okay.
Hi, my name's Pat Richards. I made it to the meeting on time. I didn't think it was possible tonight. My day started out bad, and nothing's gone right since, but I'm actually in a better mood. I'm still in pain, but a lot's changed since the last meeting. Because last meeting I came to, of course, I got lost and got here late and caught half of the party. And anyhow, my diagnosis will be Saturday. I'll have 6 months. It'll also be my 16th wedding anniversary. Anyhow, I got up and went to my chemos when I didn't know my regimen. Since the last meeting, I fired my last doctor. My second opinion one at UCSF was going to take a wait-and-see approach, which seemed like he wasn't going to do anything. And so, and I thought I was transferred, and he didn't know it, so I was lucky. And I found out Dr. Dorm, and he was in my network. And I went to him on my first visit and made an appointment. We transferred that first day, and he gave me some information. And when I got home, next couple of days, I got my PET scan, and I emailed to Dr. Dormady because my first scan after 4 months showed everything reduced. The second one, 3 places started growing again. So we were going to do 6 and 7 or 7 and 8 of Paxil, whatever. But since it's not working, I emailed Dr. Dormady, PET scan. He said he had a colon he seemed to have success with. So between Sunday and Tuesday, he got a couple of the drugs approved, which is pretty good. And so I had them last week, and this week I was supposed to get 2 more drugs, and I guess one's still not approved. And unfortunately, I was supposed to get a port put in for one of the drugs last week because my first treatment I had no pain. And this one, a lot harder. So anyhow, I wasn't taking the pain meds because I also get lower bowel obstruction. And between my diagnosis and the scan, I was in the hospital for 5 days while they pumped my stomach, so I have to walk. But I didn't want to take the pain pills, so I had to suffer that. So Friday I didn't sleep, and then I emailed Dr. Doherty about taking pain meds because he said, talk to the doctor before you take them. And I had to take it anyway. I couldn't wait anymore. So I woke up in pain this morning, and nothing went right since. I go to the chemo, and I didn't know I was supposed to get a port put in, so I get the same shot that causes the pain again. And I get home and realize that I got 2 chemo meds I was supposed to take before the chemo I didn't take. So, but you know, things are, I mean, Dr. Doherty drew me a picture of the cancer I have. I guess I have it in 5 places, but it doesn't look that bad. I mean, some of them are nodules or whatever. But I think a couple of things weren't mentioned in my scan. I had 2 previous ones. T10 or something's missing or something. They didn't comment on it. But so I left and I said, I'm going to be late again. And somehow or another, I came a different way, and I made a right on the street that leads to this meeting. And I made it here in time. I'm glad. Thank you.
I'm Nita Durand. I don't know if you can hear me. If you can't, wave your hand, because I hate to sit here and watch people's mouths move and not be able to hear them.
We can hear you very clearly.
So I was diagnosed in July of 2009 with non-small cell cancer, adenocarcinoma. And it was stage 4. It had spread to the bones in my hip. And Jim and I went to a couple of different places to get some diagnosis and confirmation of diagnosis as well as treatment. And we went to MD Anderson, and they suggested strongly, I was kind of opting for surgery, but they said, no, you're not a candidate for surgery. This tumor in your lungs is too close to the aorta and so on, et cetera, et cetera. But they said you would do yourself a favor if you would have someone blast the cancer that's in the pelvic bone. And so that was the first thing we attacked. And we had finally settled on a physician at Stanford and an oncologist at Stanford, but we used their nuclear medicine and so on for the radiation of the pelvis. And then we started out on chemotherapy, and we did the cisplatin, carboplatin, gemcitabine, and so on. And it made me dreadfully ill. I could hardly walk around the block. I was so sick. And finally, she said, well, this just not working. Yeah. And in January, they finally did a molecular, what do they call it, Jim? Screen. And it turned out that I had EGFR mutation. So they started me on Tarceva about the end of January. And that went just swimmingly for a long time. It cut the size of the main tumor in less than half. I mean, it really reduced it beautifully. But I have a lot of nodules throughout my lungs, so they're watching those. And then after a while, this past year, the Tarceva stopped working, and the main tumor grew in size. Meanwhile, the satellite tumors, I like to call them, they were doing their own thing. Some of them really responded well, still to the Tarceva, it seemed to us. But finally, we decided to do radiation to the main tumor. And that seems to have gone well. They're still watching the residue of this, but it seems to have gone well. And I'm continuing to stay on Tarceva because it seems to moderate or at least tamp down the growth of the nodules. So that's where I am now. And everything from 4 months ago, I had a scan, and I'll have another scan in 4 more months. And it all seems to be stable, at least not growing like just the way I'd like it to be stable. So that's where we are right now, just hanging in there.
I have nothing to add.
My name's Orrin Walker. I was diagnosed with adeno cancer, lung cancer, and brain cancer in August of 2011. So far, I've been beating it, I guess. I did the radiation treatment first. There were two, what do you call it? Two lumps, one in my upper brain and one in the lower brain, about the size of my fingernail. And those were, after 10 treatments of radiation, they're almost gone. After that, I went to chemo, and it's, I went all the way through the 6 treatments, and they decided it was time to go to the reduced treatment. And I'm in that right now, and I'm stable, but I don't like being stable. I want to get cured. I want to know what we can do to get rid of the stable stuff and get cured. I'm about 85% cured in my lungs, but I have in my third lumbar, I have a pretty good tumor. And I still have the same tumor on my, I can't think of it. It's the air duct that goes between the two lungs. And it's quite large. It's the size of a golf ball or bigger. And it's still there, and it hasn't changed. And I want to get some of that gone. So that's my question. I went to Stanford for a second opinion because I'm being treated at Kaiser in I can't think of the name of the hospital. Santa Teresa Hospital. I'm sorry, I don't have any memory, which is part of this. But yeah, I want to find out how to move forward. Thank you.
Okay.
Thanks, Warren.
Hi, I'm Neil. I was diagnosed a year and a half ago, so June 2011. I had a phone consultation with our guest tonight, who very graciously gave me a lot of his time, answered a lot of questions for me, which I wrote down, typed up, and brought the next day to Dr. Heather Wakely at Stanford, who said the exact same thing.
That's a relief.
And I figured either both of them were in cahoots or they knew what they were talking about.
Dr. Wakely's an excellent doctor, so I concur.
And it was verbatim, the same exact information. So I knew that they probably knew what they were talking about. So I got diagnosed at that time. because I had the EGFR mutation, so I did 13 months on Tarceva, and for me, it was a great 13 months. My only adverse effect was that I had even more energy than I normally would have. Very rare versus most people who have a far different type of response to it. But it was great. I passed the median of effectiveness, but I was hoping to be way past the median line before it would start to mutate and become something else. So of course, like most other people, it did start to mutate, and for the next 4 months or so, so that's from last August until just recently, I did the Alimta and the carboplatin. And as far as I'm concerned, systemic therapy, which is really poison, is if you can forget about it, forget about it. If it helps you, wonderful, but really, in terms of what it does to your body versus targeted therapy, I'll take targeted therapy any day. Last week, so a week ago Monday, I started a clinical trial at Stanford that's also being done at a few other institutions in the US and also in England by Clovis Oncology. And it's listed, I'm not sure if it's listed as a second generation type Tarceva or third generation. The idea of this particular medication, I believe, is to turn off in a better way the effects of the cancer for a longer period of time, to hit more receptors than the Tarceva did, and also perhaps to attack the most prominent mutation, the T790M, as some others have mentioned tonight, that typically, I think approximately 50% of the people who have the mutation, EGFR, and then the Tarceva stops working, have. So I started that a week ago Monday, and I'm in the 11th cohort, which means that I take 1,200 milligrams daily, because they're still trying to figure out how much they can give to an individual before they really make them sick, or it's not working, or something like that. So far, I do have to tell you that at the 27-hour mark of taking that drug, I did notice a difference in symptoms. So that was on day 2. It significantly reduced the coughing that I had. While not eliminating it, it has cut it down significantly. And at the same time, probably because I've been off the systemic therapy for approximately 4 or 5 weeks, my energy level is, it's coming back to, where I like it to be with the type of things that I do. Whether the drug works out in the long run, I do not know. I did have a biopsy recently, which has not yet determined whether I have the T790M mutation, because it's done by batches, and I believe they've just gotten that, and there are other people that also have to be checked. What I do know is that some of the hesitation that I had as being part of a clinical trial have been obviated by getting more information, and especially about not being the first person in the first cohort for some of the trials, which is at the lowest possible dose, and who knows if that will help at all. I guess a question that I would have and ask Ross to perhaps later address is, there are various stages of clinical trials from the phase 1 and 2 and 3, and then getting approval from the FDA. And in most cases, it takes a long, long time from the beginning until it finally gets able to be prescribed by any of our doctors. And I'm just wondering, what can be done at each of the stages to hasten that process without reducing any of the due diligence that has to be done, so that it doesn't take 5, 6, 7, 8 years or whatever. I know in the case of crizotinib, it's something that came out a little bit sooner perhaps than maybe some of the other drugs did. I'm not sure about afatinib, how that was done, how quickly that was, or I know now it's going up to the FDA for approval, but if you would address that a little bit later, so I think that would help us. And perhaps help some of us who are pretty hesitant maybe at going into clinical trials and have questions about it, and it may help us make that decision of why we really should participate when so very few people actually do participate, who perhaps are a very small minority of the ones who are eligible to do it. So thank you, and I'll pass it on.
Bill?
Hi, I'm Bill Kipp. I was diagnosed just like Mr. Walker, in August of 2011, and I have adenocarcinoma, stage 4. Let's see, when I was first diagnosed, because I was EGFR positive, I actually used Tarceva as a first line, and it worked brilliantly, but only for 2 months. And so, let's see, January of last year, I did, it was carboplatin, Alimta, and Avastin, 6 rounds, and now I'm doing Alimta and Avastin about every 3 weeks for maintenance, and it's going well. And anyway, the same thing, I think a lot of people here, Dr. Camidge is very good about answering emails, and he actually helped me kind of navigate some of the choices when the Tarceva stopped working. But really excited to hear you speak, so I'm going to cut it off there.
Right behind you.
My name is Terry Fry, and I'm here because my daughter was diagnosed with 4-stage lung cancer when she was 32. She'll be celebrating her 3rd year as of March 18th, so we're very excited about that. She first was treated with the 3 combo of carboplatin, Alimta, and Avastin, and it shrank very well. She was initially going to get surgery, but then they found the cancer in her lymph nodes. So we sent her tissue back to Boston to be tested for ALK, because at that time Stanford didn't do it. And so it was negative, but while it was out there, they tested it for the new ROS mutation, and she came up positive. So the decision was made to keep that as our plan B, because she was still doing well on the Avastin and Alimta, and she was on that for about another year, and then now she's just on Alimta. She went in, she had one spot on her left side that was not shrinking, but it could be scar tissue. So just about 4 months ago, she went in and put fiducials in and had that biopsied, and it came out negative. But she went ahead and decided to get radiation on that spot. And so she did the targeted radiation, and now she's hoping to go off of chemo after her next scan if everything looks good. She wants to take a break from chemo for a while. So she's more concerned about the fact that she's only 35 now, and she's been on chemo for such a long time that might. But in addition to the chemo that she's been doing, she goes to acupuncture and organ massage 3 times a week, and does a lot of supplement medicine, which I really do believe has helped her immune system help fight this. If it wasn't for lung cancer, she's actually the healthiest she's ever been. So.
And she's telling me that you're on voice rest.
I am on voice rest, and but I wanted to also thank Dr. Camidge, because he also has graciously talked to us on the phone about Natalie's treatment, and was very helpful in helping make a decision about getting the second biopsy and the radiation. So I want to thank you.
It's nice to put faces to all these people I've communicated with.
Linda?
Well, hi, everybody. My name is Linda. I am from San Diego. I come up here as often as I can, hopefully monthly, but it depends on how my daughter's feeling, whether I make it up here, but it's worth the trip. This is a great place to be, great place to get information. Anyway, excuse me, I don't know where that's coming from. Anyway, my daughter was diagnosed like Terry's when she was young, 38, never smoked in her life. My husband and I never smoked, so no secondary smoke involved. But she's got the stage 4 lung cancer, and she started out with the triple cocktail, and then after that for a few months, and she was diagnosed in September of 2009, and after about 6 months of the chemo treatment, then they put her on Avastin as a maintenance chemo, and that went great. Once a month, at that time she lived in Palm Springs, and so she drove over to San Diego for her treatment, and she could get her treatment of Avastin and walk right out. She has a little son by herself, and he was at that time 2 and 3 years old, and turning 3, and she could drive right home to Palm Springs, and she was fine. And that went on for about 2 years. But then I think it was this past June or July, it started kicking up again and had transferred to her stomach area. So they put her on, they've put her on Tarceva, and but she didn't have the mutation for that originally, but they said, and I've learned from these meetings, you can still get Tarceva even though you didn't originally qualify for it. And then they put her on a second chemo, and I can't think of the name of it, but it made her really, really sick. And so finally, around Christmas time, her doctor said, well, we'll give you a break from that for a while, because she was not eating anything. She had a million mouth sores, and she couldn't even get water down. So she's gone down to, very low weight and not able to eat at all. So they gave her a break during Christmas vacation, and now she's starting to eat a little bit again, feeling a little bit better, still on the Tarceva, but the doctor wants to put her back on that other, I call it the strong chemo, but she's going to put her back on it at a lower dose. So I guess my question tonight would be, if you go on a medication or chemo on a lower dose, does it work as well? I mean, I don't know.
Are they giving a lower dose but more often?
I don't know. We're not at that point yet.
Okay.
When we, another week or so, we're going to see the doctor, and then there's going to be another scan, and then they'll determine what they're going to do with that dosage. But I don't know, I guess it still does something, but maybe not as strong as the original dose would be.
Hopefully Danielle's writing some of these things down, and we'll make sure we cover them.
I didn't hear that.
Hopefully
I'm writing it
Danielle's...
down so we come back to it.
So
Oh,
we can come
okay.
back to it.
Thank you, and thank you.
She's still with Dr. B, yeah?
No, she's with Ludmila Bajnova.
Yes, yeah, B, yeah.
Oh, I thought you
Yeah.
said Doctor.
Yeah, that's okay.
Another name.
Okay, yeah.
Yeah, she's still with her, and
Okay.
she's so far, we're happy with the treatment down there. So.
Lynn, do you want to introduce yourself? She's got one.
Hi, my name's Lynn. I haven't been back here for 6 months since June. A lot has happened since then. I was diagnosed in May of 2011 with stage 4 lung cancer. I do not have the mutation of EGFR, so I was on the cocktail of carboplatin, Alimta, and Avastin for the first 4 cycles, and then my tumor shrank, and then so I was on the Alimta and Avastin for another 9 months. And then it stopped working in April, so I was put on Gemzar, and that didn't work out. So in August, I had 2 brain mets. I had 2 tumors in my brain, and I did CyberKnife. That took care of that, and then had blood transfusion, and then took a trip to Paris in November, but had pleural effusion the entire 8 days I was over there, and somehow made it back here on a 12-hour flight. Went to the emergency room and had it drained. And then I was put, in August, I was put on Navabine chemotherapy infusion, and that made me really sick. Plus, it didn't shrink the tumor any further. It made it worse. So I decided to stop chemo completely beginning of December. And my cough came back, and my lung pain came back really quickly. And I was referred to Stanford, so luckily, I was the last person to get into this new clinical trial they have. So it's the clinical trial is part with Tarceva and Davitinib, which is another drug that they're going to put together to see. It's only a phase 1. So I just started the Tarceva on December 28th, and 2 days later, my cough and my lung pain literally went away. I don't know how or what, and I can eat again, and I have more energy, and by gosh, I know I don't have EGFR. I don't know what's going on, but I'm glad. And so next week, I'm going to start the new drug, the Davitinib, with the Tarceva.
So you're improving just on the Tarceva
just
alone?
On the Tarceva.
Had you ever tried the Tarceva before?
Never.
Okay.
I've been on chemo. I've been through 42 rounds of infusion chemo for 19 months.
We should talk about false negative results on molecular
Probably.
testing at some point.
But I'm negative on the ALK and KRAS and everything else like that. So I'm seeing Dr. Neil at Stanford now, and he believed there might be a rare EGFR mutation that I might have that's not identified with.
The devil's in the details on the molecular
Right.
testing. Yeah.
So I don't know if it's working, but all I know is that I just have a lot more energy right now, and be able to move on to the next step. So we'll see what happens.
Good.
So, is everybody in back fine? Nobody wants to? Okay. And nobody online wanted to introduce? The people that are actually chatting. Oh, good. Okay, we'll give a shout out at the end. Okay, thank you everybody for sharing your stories and for making them brief. I know sometimes that winds up taking a lot longer than 35, 40 minutes. So I really, really appreciate it. We're gonna move on into learning a little bit more about Dr. Camidge and start with how you wound up in Denver from England and all of that good stuff, and how you got into lung cancer.
All right, so I'll briefly introduce myself, although obviously this is about you guys, not me. As you may have figured out, I haven't got an American accent, I think. So I entirely trained in Britain, and towards the end of, so I did slightly funny training. I did a molecular biology PhD, and then I went through medical training, and then I was the test pilot for a training program that combined medical oncology with something called clinical pharmacology, which is drug development. And by the time I got to the end of my training, someone had offered me money to go to America for 2 years as a finishing school. And I was single at the time, and I didn't have it. My mother wasn't terribly pleased, but I came over, and I got offered jobs from lots of places, because if you're bringing your salary for 2 years, most people don't turn you down. And the last place I interviewed was in Denver, which was an area I'd been to the East Coast and I'd been to the West Coast, and the bit in the middle I'd always flown over. And I was attracted by three things. One, they were very, very strong in lung cancer. Two, they were very strong in drug development. And three, because it's a relatively new center, the first words out of their mouth whenever I suggested something that could be done wasn't no. They might have said, well, we don't know how to do that, but we're really interested in finding out. Whereas some of the more established institutions were a bit more fossilized, and I was very interested in doing something new. So I moved there in late 2005, and about 6 months after I arrived, my colleague Karen Kelly, who looked after your daughter, left. And sort of left me holding the baby. So I became the sort of de facto director of the clinical lung cancer program about 6 months after I arrived, which was a sort of rather rude awakening. And then that sort of settled in, and we added more people. And I've been there ever since, and I got married, and we have a 3-year-old and a 1-year-old who are hopefully in bed by now. And apologies to my wife for having to put them all to bed yourself tonight. And I ended up in lung cancer. So I did most of my oncology training in Edinburgh in Scotland. And I ended up in lung cancer, even though I went through all of the different tumor types, and there was something attractive and needy about all of the people who were affected by cancer. There was something about lung cancer. And I realize I'm preaching to the choir here, that lung cancer patients I felt were desperately in need of breakthroughs and advances, and I just really liked the people. So that's how I ended up in lung cancer.
So I think everyone here knows what they think lung cancer is, but what do you think lung cancer is?
So sometimes when you meet people, you have to explain that lung cancer defines a cancer that starts in the lungs, even if it spreads to somebody else. So when you speak to an oncologist and you say, I have liver cancer, they're going to correct you and say, no, you have a lung cancer that spread to your liver. You can get cancers. So cancers are named after where they start, not after where they go to. Traditionally, and you all know this because for those of you who have been smokers, you know that the first question people ask is, were you a smoker, with that look of now my sympathy for you is evaporating. And if you're a never smoker, they just assume that you're lying and that you must have been a smoker somewhere along the way. So certainly the majority of lung cancer has been associated with smoking exposure, but there are two things to take away from that. First of all, even though, maybe, and it depends on where you are in the world, but at least in the Western world, sort of, 85 to 90% have some kind of smoking history, but about half of those may have quit smoking decades beforehand. And the other thing is, that's 10 to 15% in the West who've never smoked, and if you're in the Far East, it's maybe about 40% who've never smoked. And because lung cancer is so common, that's a huge disease in and of itself. The other thing is that I'm very pragmatic, which is I don't care if you smoked. It's about dealing with what we're dealing with, and there's no point playing the blame game. So lung cancer to me is actually now clearly many different diseases that just happen to start within the lung with the whole aspect of molecular heterogeneity coming out. That story started probably way back in about 2004, where a series of different groups described these EGFR mutations, and many of you know about this because you've been labeled as having EGFR mutations in your cancer. And you always have to explain to people that you're not mutant, it's the cancer that's mutant, you're totally normal. And you have to explain that because sometimes people worry that they've passed it on to their children. But I remember giving a talk in a large cancer center that should be nameless, when the EGFR mutant story had come out, identifying this subgroup of people who are exquisitely sensitive to Tarceva, and standing up and saying this is the tip of the iceberg, and we will find other things. And I do a lot of the earliest studies, so phase 1 studies when you're first trying drugs out in people, and you would occasionally get these people who had these wonderful responses to a drug and you didn't even know what it is. And so the implication was that there were super sensitive subgroups was clearly out there. And I didn't exactly get booed off the stage when I said it was the tip of the iceberg, but there was a pervasive feeling in the kind of 2006, 2007-ish time that no, there's EGFR mutants and everything else is so complex that we'll never figure it out. And fortunately, that's not the case. And a couple of years later, 2009, the ALK rearrangements came out with wonderful responses to crizotinib. And now there's this laundry list, admittedly, of smaller and smaller slices of the pie being described. Many of them are still works in progress, where people are trying to say, well, you've got this mutation, and I think this drug might work, but whether, tab A and slot B is actually going to work is still going to be figured out. The other elephant in the living room, as it were, is even with all of the molecular testing that we currently know, there's still probably going to be at least 50% of lung cancer which are not driven by mutations or things called gene rearrangements, i.e. things that if you take the DNA, all of that stuff that codes for stuff in cells, and you read through it, it appears to be normal. So one of the elephants in the room is what's driving those cancers, so what's essentially a wild-type cancer. So wild-type goes back to genetics and fruit flies. So normal-looking fruit flies are called wild-type, and funny-looking fruit flies are called mutants. So oncologists tend to use wild-type when they say there's no mutation there. So what's driving those cancers? And a lot of theories are out there. Some people are thinking that it's elevated levels of normal signaling molecules and normal receptors. So there's no funny sequences in the DNA, but they're speaking to each other. So that's called ligand receptor pairing, and I think that may come in the future. But I'm slightly getting off topic. That's my first answer.
That's your first answer?
Yeah, and I'm sticking to it.
So I think that's a great answer. Where do you see sort of the future of all that going? And I know I'm kind of jumping ahead, but and what's it going to take to get there? You know what I mean? To the smaller pieces of the pie that you're talking about, like, because when I sit in these meetings and I see the pie charts and I see the huge unknown portion, I'm assuming those are all going to be built up or filled in, hopefully, with smaller slices.
I don't think all of them will. I guess that's the point I'm trying to get to. But we talked about the devil in the detail in the molecular testing. So some of you will have been tested for some things, but if you're negative for the common things, doesn't mean you should stop looking.
Right.
So I think you need to, particularly if you have never smoked, where there's a much higher instance of these molecular abnormalities. So if you're a smoker, there's a bigger unknown slice of the pie. But I still think if it was my mother or my father, I'd want someone to be looking for these abnormalities. So I'm a big advocate of testing everybody for everything that we know. So some of the people I'm interested who have said, well, I'm negative for these things. My answer is, well, what else haven't they tested you for?
Right.
So there's ROS1 rearrangements, where you heard that story over there. There's BRAF mutations, there's PI3 kinase mutations, and all of this can be done. Now, I still say about 50% you can get that done, and there still won't be anything. And that's okay. I mean, that's still very much a work in progress, and there are clinical trials you can try, and there are standard chemotherapies. The other thing to pick up on, which kind of goes back to your point, is we all assume that these tests are all identical and that they're the eye of God, and they're, you open the envelope and it says you do or you don't have it. When you get used to the molecular testing, the first thing you do is you don't just look at the bottom line that says positive or negative. You look above it to figure out how they did the test. So let me try and explain with a real-world example. Okay, so EGFR mutations. So mutations are changes in the DNA. And in DNA, only certain bits of the DNA are informative. And they're like beads on a necklace, and there's kind of junky DNA in between them, like the string on the necklace. Those beads on the necklace are called exons. The meaningful bit in the EGFR, where these mutations occur, is 4 different exons 18, 19, 20, and 21. Now, most EGFR mutations occur in exons 19 and 21. So there are a number of assays that will just look in those 2 exons. So they'll either read from left to right, the whole of that exon, left to right, and the whole of that exon, or they'll be very specific, very sensitive assays that say the specific mutation we want is, funny letter, funny number, funny letter, and they'll come in and just with a microscope, they'll look just at that bit, and they'll say, you do or you don't have L858R. But they won't tell you if there's something else right next to it, because it's so focused. So as we learn more about it, the assays have become very streamlined, and they're very good at answering very specific questions. But if the answer comes out you haven't got one, and they haven't done these other things, you could still have a rarer EGFR mutation that's sitting in exon 18, or a rare one sitting in exon 20, or an unusual one sitting in either of these other common exons that just they missed with the very specific assays. So that comes back to maybe what Dr. Neal was getting at, because it depends on how they did the original assay. The fact that you're feeling better on Tarceva makes me feel that you probably have an EGFR mutation. They just missed it. And there's some incredibly small print stuff which we don't necessarily need to go into, where you can't even find that, and it's some other thing. But I don't think that's what he's getting at. I suspect the assay that you had. I realize I blinded you with science a wee bit there, but the other thing to take home is the material that they're doing the testing on. So they have to find a needle in a haystack. So the more cancer cells in that specimen they're looking for, and the less normal cells, the more likely they are to find that needle. So many reports, so some of the commercial companies will have a line that says, this assay is invalid if there are less than 20% tumor cells in the specimen. But nowhere in that report have they traditionally said, how many tumor cells are in the specimen? So you can't interpret that. And I've gone to these companies and said, well, that's just your get out of jail free card, but it doesn't tell us anything useful. What you really want is someone that says, this is an uninformative assay because there's not enough tumor cells in this specimen. So even though it says negative, maybe it's not. Go and have another biopsy. So the classic one where it's a problem is, for example, when you get the fluid from the lung, so pleural fluid, because you've got some cancer cells in there, a lot of fluid, and a lot of normal cells that are just floating around, and they spin it all down into a little glob, and they look at it under the microscope, and maybe, if this rug, the camera's not going to pick up on the rug here, but anyway, there's a rug on the center of the floor, and if most of that is normal cells and only one corner is tumor cells, and they look for it, mostly they'll get the signal from the normal cells. So one of the key things, often about academic labs more than commercial labs, because it's more labor intensive and therefore it's not terribly cost effective, is they will microdissect. So they will take that specimen and then they'll actually have somebody who, under the microscope, will cut that little corner of the rug out and then just look there. So again, if you have a positive result, don't sweat it. But if you have a negative result and you say, I've got to have something, then you really need to go to an expert who can understand how they did the assay and, if necessary, retest you or rebiopsy you.
So, Ross, does that go the same for fusions like ALK? I mean, does that all work?
Yeah, so ALK is it's a different assay. So most of the ones where there's a little, there's one letter changed in the coding sequence. You're just you have a computer program essentially that reads the sentence from left to right, and there the detail is because they're looking at the mutant sequence. And that sequence, which is also present in a normal version in all of the cells, it's about the amount of cancer cells in there and how they actually look at it. For ALK, it's a different test. There's only one FDA-approved test, although there's other ones out there. The FDA-approved test is a beautiful test. I mean, it's artistic to look at. The gene in ALK breaks in the middle, and the kind of warhead of ALK is joined to some other gene, and it's the fusion of the two things which drives the cancer. The test has a little red and green dot on either side of where that break point occurs, and if there's no break, the red and green dot are right next to each other. But if there is a rearrangement, the red dot stays here and the green dot goes over here. And you see these red and green dots separate, actually looking at the cells. So it's very beautiful to look at. But it's a very subtle assay. And it's in the hands of somebody who's not doing it, or is doing it for the first time, they can miss it if they're only separated by a little amount, or overcall some cells, undercall some cells. And we know an example of somebody who Bonnie sent to me who was called ALK negative, and we retested them and they were ALK positive. Mm-hmm. So if you've got a positive, great, you've got your label and you can chase that down, and we can talk about acquired resistance in a second. But if you're negative, and particularly if you're a never smoker, then you need to go to a center who knows about this to just really say, am I truly negative, and don't just sell me down the Swanee.
Microphone. Oh, right.
Mike.
I'll try to be as coherent as possible with this. My question ties exactly into this because of the issue of survival of only being 15%. And is lung cancer especially complex? Because for someone like myself, and for instance, I am wild type. I did have genetic and molecular testing. I've been a never smoker, and yet I came out wild type, which essentially means that I was essentially negative, not strongly positive to any of the genetic markers, yet I've responded extremely well to Tarceva, and matter of fact, they're calling me their poster child because I'm on my 54th cycle. But when what you're talking about, in my case, they also said that I don't have a pure cancer, that I'm mixed. And doesn't that also add complexity when you're trying to get a biopsy, and maybe one portion of even if you do have cancer tissue, it could be something, some of it responds to, let's say, a drug, and another portion of it doesn't because it's actually two different possibly cancers mixed together?
Yeah, I mean, you're absolutely right. The whole idea about heterogeneity within an individual, either between deposits of cancer or even within one deposit, is just starting to be realized. They did a very nice study in kidney cancer, which was published last year, which produced one of two reactions, either complete terror or excitement, because what they showed was the amazing amount of heterogeneity within one cancer within one individual, and you could see individual clones coming out, and they essentially had a family tree. You could see that they went down there and they got another mutation. These ones went left, these ones went right, these ones made another decision. And in the press, the people who are kind of glass half full said, this is amazing, we're really starting to understand, this is where the field needs to go to actually decide how do we treat this. Do we need to get quantitative assays that says you're this proportion of that and this proportion of the other? And the people who are glass half empty went, oh, panic, and it's all going to be doom and gloom, and that's the wrong attitude, because you're never going to make progress with that. It depended on the quality of the newspaper which way they went. So yes, for you, again, although this is a long-running debate as to whether people who do not have an EGFR mutation respond to Tarceva. And the reality is, while scientists may believe that there is a mutation there, it's just missed, on a totally pragmatic level, because you cannot say that the assays are 100% sensitive, either because of some vagary of the assay, or your point, maybe 99% is, but the 1% they biopsied just didn't have it. If you've got nothing else to try and your back's against the wall, why wouldn't you try it? So I think we need to be careful about being too lulled into, how incredibly smart we are by saying you don't have the assay and therefore this drug has to be totally off the table.
Exactly, because they at any other place except for my doctor, I believe at UC Davis, they might have said, well, since you're negative, we're not going to even try it. And here I have responded so incredibly well. So that's, kind of the downside of the molecular testing, but it's so minor because, again, hopefully the doctors are sophisticated enough to say, okay, I still think that this will work.
So my backup question to that, it would be, when do you decide to try something that the tests are saying won't work versus a drug that sometimes works?
You've got to start to become comfortable with risk.
Right.
And when I went through my PhD, the moment of realization, which was actually when I'd finished my PhD, but I guess that's the right time to have finished your PhD, was the essence of science was being comfortable with shades of gray. Initially I thought you go into science and you get the answer and it's black or it's white. But it's not. You realize that every single fact that's out there, and for those of you who've tried to hit the internet and try and interpret this literature, is, how much weight do you put in it? And it's much more kind of like walking across a pond, and how much weight do you put on each stepping stone? Some you feel it's really solid and you can really jump up and down on it. Others it's a bit more shaky and maybe it's going to start to sink and the data's going to change next week. So you have to be comfortable with these shades of gray. So let me come back to the idea of risk. What that means is, if you have a test that says you don't have a mutation, while we cannot say there's 0% chance that you will respond to the specific drug, we recognize that that's clearly a lower chance than, for example, chemotherapy that might have a 30% response rate. Mm-hmm. So what you're using that information for is to prioritize the order in which you try things. So when you don't have the mutation, it becomes more of a Hail Mary pass. Mm-hmm. But for those of you who watch the Broncos crash and burn at the weekend, occasionally you need to do a Hail Mary pass.
Well, can I ask you, is there any hope in doing in vitro experiments or mouse model experiments where you could try many therapeutic trials in a short time?
Yeah, so the whole idea of what's called primary explant, so that means they take a biopsy of your cancer, and instead of just pickling it and doing these tests, in the laboratory as we currently do, is they stick it in a mouse that doesn't have an immune system, so it doesn't reject it. They're called nude mice. They're ugly-looking things that were developed in part of Scotland. I seem to remember Strathclyde University, I think they were developed. Small Scottish reference there. And these things can grow, and as they grow quickly in the mice, and then you can kate out the mice, cut it into little bits, and put it into 10 other mice. And so you can have a virtual you growing in parallel. And you can treat one set of mice with, one set of drugs, and they can be chemotherapy, they can be some of these targeted agents. And instead of you having to go through them sequentially, maybe the mice will give you the heads up. That is certainly attractive in theory. And there's a number of companies who, for a fairly sizable chunk, will actually do that commercially. Some of the results so far have not been that surprising. They've given, if you like, proof of principle. I think one of the problems is our list of available drugs, the ones that you can go to your private oncologist and he can open the cabinet and give you, is still relatively limited. It's standard chemotherapy, and it's Tarceva, and it's crizotinib, and maybe it might be afatinib soon. Whereas what you want is you want them to be trying all of the experimental stuff to say, now you need to go to this clinical trial or that clinical trial, and that might come. Does that answer your question?
Yeah, I have a question for you.
Sure.
We have been told that if you are EGFR, if your cancer is EGFR positive, that it's highly unlikely that treating something that's for your ALK mutation, which you're highly unlikely you will have an ALK mutation that will make it your cancer sensitive to drugs that are aimed at that.
Okay.
How do you feel about that?
So, yes. Again, one of the key things is whenever you start to discover things, your data set always starts off relatively small, and one has to be careful not to create dogma when your data set is relatively small. Now, one of the early dogmas was these things are all mutually exclusive. And I think, just as you were saying there's heterogeneity in people, I think there's an emerging body of evidence that there are rare people who have both. Now, they're probably not in the same cell. They're probably, like I told you with the kidney cancer, one decided to go left and was driven by an EGFR mutation, and one decided. They're the exception, I got to tell you. And the rates range from 0% to about 13% in studies, but they're all small studies. The reason why I say this issue about dogma is a few people picked up on that idea of mutual exclusivity, and then they said, well, you should do sequential testing. So I test you for an EGFR mutation, and if you have one, I'm going to stop testing. And I'm only going to test you for an ALK if you're negative for the EGFR, and or whichever order they wanted to do that. And while there are certain resource utilization and health economic arguments, and we can touch on those if you like, from a scientific point of view, that's very unsatisfactory. And I actually think sequential testing is a bad idea, exactly for the reason that you're suggesting. But do I think it's likely that an EGFR mutant is going to be ALK positive? No. But it's not zero chance either.
This gets into a lot of the talk that's going on right now about rebiopsying because cancer changes, and when is that a good time for a patient? And we talked about rebiopsying if, like in Lynn's case, if your test comes up saying, nope, sorry, there's nothing for you, yet Tarceva is working, test again, whatnot. But rebiopsying for purposes of the cancer has actually changed post-therapy.
Yeah. So I think rebiopsy comes in two forms. One is if there isn't enough material to do the test that you want to make that initial diagnosis. And then the other one is, and there's many people sitting in this room who said, well, I was originally on Tarceva or something else that worked great, and then it stopped working. Now you have to at this point, you have to stop thinking about your cancer as one blob, and you have to think about it as a population of cells. So if I try and use an analogy, okay, so everybody in the room is now a cancer cell in one tumor, and I'm giving you all a Rubik's Cube. And the Rubik's Cube is how to get past the drug which is currently suppressing you all. Now, I would still be working on the Rubik's Cube in about 5 years' time, but maybe some of you are much smarter than me, and you'd be standing up in different proportions along here saying, I figured out the way around the drug. Now, what that means is your cancer is doing the same thing. Each individual cell or each generation of cells is trying to figure out another little change that will make it get round that drug. And when it does that, it doesn't happen in every cell in the cancer simultaneously. It happens in one, and then it has, it's like you whispering to the person next to you, telling how to do it, so the children of that cancer cell do it. And it starts in one little clone and then spreads. What that means is some of you have said, well, I'm on the Tarceva, it stopped working, but they're keeping me on the Tarceva. And that's because the Tarceva is still suppressing a proportion of those cells. Over time, the balance is going to shift, so there's more resistant cells than sensitive cells, and that's probably the time when you have to shift things. But there's a growing awareness that people who either just have one spot that's growing, and you can maybe zap that with radiotherapy or cut it out and keep the Tarceva going, or even just allowing very indolent growth to go on. Because being on the Tarceva and acting as a brake on the system is better than not being on the Tarceva for many people. But to try and answer your question, when you get to the tipping point, when you feel like you have to change the big picture, the more you can find out how the cancer's got smart. So, I guess my analogy breaks down now because there's only one way to do a Rubik's Cube, but how it managed to get past that drug becomes important. Because if there's a pie chart of different cancers to begin with, each slice of that pie chart can become another pie chart when it becomes resistant. So you become resistant in different ways. And by rebiopsying and reanalyzing at that point, rebiopsying a growing lesion, you can then try and direct usually to a clinical trial as to, whether you've got T790M or whether you've got MET or whether you've got something else.
Makes sense. Somebody online wants to know, would a doctor maybe not prescribe a targeted drug to a patient who tested negative because of potential legal ramifications to that physician?
So for Tarceva, no, because Tarceva has a license for everybody, and indeed the manufacturers of Tarceva have, done a valiant rearguard action to say it's not just about mutations. They may not necessarily be in agreement with many of the academic oncologists on that part. It's going to be harder for something like crizotinib because the wave of the future is identifying the group that does best, because that's where you get drugs licensed very quickly, because crizotinib works so well in a defined group. And technically, its license is for people who are proven to be ALK positive with an FDA-approved test. So if you were to give it to somebody who is ALK negative, the physician would be giving it off-label, as it's called. But physicians do that all the time.
Right.
You just accept the liability. But they need to be realistic with the patient. They need to say the chances are slim, but if your back's against the wall, go for it.
Another online question: if you could change one thing today,
other than the Broncos result.
Yes. To have impact on lung cancer, would it be better and earlier diagnostic tools for early detection, better and more drugs available to patients, or drug delivery options other than pills?
And those are my only three options.
Oh, other than pills and obviously intravenously.
So somebody had talked about cure, and if we actually, there are two ways that we're really going to change the outcome of lung cancer. So one is to cure more people, and the other is, if we use the HIV analogy, is to convert it into a chronic disease. So nobody's cured anyone with HIV. But I read the statistic on the airplane over. If you're a 20-year-old diagnosed with HIV in the middle 1990s, you had about a 10-year lifespan. If you're a 20-year-old diagnosed with HIV now, you have an additional 26 years lifespan, but none of them are cured. And I'm sure that number will go up. So we're starting to add decades to HIV through increased understanding, a lot of increased funding, and access to better drugs. So turning lung cancer into a chronic disease is going to be probably, for most people who are diagnosed with advanced stage, what we're going to get to before we get to cure. We'd love to say get to a cure, but I think in my lifetime, the thing we're going to get to first is turning lung cancer into something like diabetes or hepatitis, something that you live with even though you still have to be on some kind of medication. The only way we can, I'm going to come back to how could we actually cure stage 4 lung cancer later if you like, but the only way we can actually realistically now cure people is to catch more people at an early stage before the cancer's spread to other places around the body. That's a real challenge. Something called the National Lung Cancer Screening Trial, looking at what was called low-dose spiral CT. So it's a CT scan of your chest, which is very quick and doesn't use very much radiation. So the normal people weren't exposed to unnecessary amounts of radiation. Did show that you could find some lung cancers at an early enough stage and operate on them that you increased the cure rate. But the reality was they only screened people who were high risk in the true stereotype. They were people over the age of 55, I think, and they had to have smoked for more than 30 pack years. That's a pack a day for a year. Is it 1 pack year, or 2 packs a day would be 2 pack years. So even for very high risk people, sure, by screening people by CT, you could pick up a few people and increase the cure rate. Unfortunately, we have to live in the real world. The health economics of that were awful, because a CT scan cost several $100s, and the number of people that you actually picked up was still relatively small. I mean, they screened thousands of people in this study, and there's a wonderful proof of principle that if you do catch people early, if you could get early detection to work, it would increase the cure rate. But low-dose spiral CT would pretty much crash the health system in the US if they actually implemented it. The other real problem with that is, what about all the people who are not age 55 and over and who haven't smoked for 30 pack years? Nobody's proved that it works at all. And there, because the risk of lung cancer is lower, the health economics are even worse. So what we desperately need is an early detection that is maybe looking for some of all these fancy molecular subtypes that we're finding, and maybe we could find a signature in the blood and then say, okay, there's something, almost like people have for PSA, although that's slightly controversial now, for prostate cancer, and say, this looks funny in your blood, now go get a CT scan. And that may come. I really think blood signatures of cancer, particularly with increased understanding of unique signatures that say, this is a molecule that shouldn't be in your blood unless you've got cancer, will start to come. It's not going to be a solution for everybody, but if we can just bump up the detection rate bit by bit, we will increase the cure rate.
But something like that, a blood test detecting X or whatever it is along with a CT? Like
I think
combining.
It would. Yeah, I think what you get the blood test, and then if it was positive, that would trigger you to then have the CT scan.
Right. Okay. Does somebody?
There's a question in the back.
Go ahead, Ray. I can't see anybody in the back. I know Ray has a. Oh, Rod, you have a question?
Sure, just very quickly.
Sorry, Ray.
Is this resistive mutation always cumulative, or have there been situations where a cell will mutate that used to be resistant to something, and then it'll mutate again and again, and then it'll be not resistant to what it used to not be? Does it ever go backwards?
Well, it does, but it's not because the cell changes. Again, just as we have to think about the cancer as a population, you have to assume that that population is turning over. And so generations of cancer cells are being created. So what happens is Darwin's theory of evolution goes on in people all the time. So a great example, and I was chatting to you guys about a case of somebody who had an EGFR mutation, developed acquired resistance. So initially they had close to 2 years on the Tarceva, and then this lady developed some spots growing. We re-biopsied her. It was actually in the lining of the fluid, so it was easy to get cells out. And she had MET, which is one of the rarer mechanisms of resistance. And what we did at that point in time was take her off the Tarceva and put her on chemotherapy, and she had a wonderful response to the chemotherapy. And then about 9 months later, this fluid around the lung started to build up again. And we re-biopsied her. And we could still see the EGFR mutation, but the MET levels had dropped right down. And has my microphone just gone off?
I think it did.
It's clearly there's editorial control going on.
If not, Dan or Scott, your hand mic.
Okay, here we go. I was talking too much. I used up the battery on the microphone.
That's what you did.
So she went on chemotherapy. She came off the Tarceva, and when we re-biopsied, the MET levels had gone right down because, again, go back to Charles Darwin's theory of evolution. You change the environment, but now because she stopped the Tarceva, you're not selecting out the ones that are resistant to an EGFR inhibitor. So she doesn't need the MET. She needs a mechanism that will be resistant to the chemotherapy, which may be some completely different mechanism. So people have described this as clonal warfare. One clone comes up, it's the dominant one because it's got an advantage in that environment. Then if you change the environment, it hasn't got an advantage anymore, and it'll get pushed down again. And there's some data that, if you think about it, now I'm not sure the logic actually applies, but let's just think about it here. If we're terrified of these mechanisms of resistance like T790M, like MET, if they're so awful, why aren't they the dominant form when you're diagnosed? And the reason they're not the dominant form when you're diagnosed is because they're less fit than the form that you presented with. So they can only be dominant in an environment where they have a special advantage. And if you change the environment where they don't have that advantage, well, the original form of your mutation will push them back down because it's the fitter form. And so people will re-manifest Tarceva sensitivity. So I don't want to oversell this. So certainly, you can get a re-challenge response. What is not known is whether taking somebody off the Tarceva and re-challenging them and feeling good because the cancer shrinks down, even though it's a slightly shorter honeymoon because those resistant cells are at a higher baseline level than when you started, whether that's in any way better than just keeping the Tarceva going through the chemotherapy and just suppressing them. And nobody knows. There are studies that are looking at the difference in what's called the progression-free survival. So chemotherapy on its own versus chemotherapy with the Tarceva going, which takes longer before your cancer starts to grow. But that's not answering the question. What you really want to know is Tarceva with the chemotherapy together versus chemotherapy followed by the Tarceva. And that study hasn't yet been done. It was a long-winded answer, but did that get to your question? Okay.
Ray.
My question is a little more pragmatic, I guess. What are the expectations, or what can we expect in the next 1 to 2 years in terms of targeted drugs being released for general use?
So afatinib, I believe, is filed with the FDA. Now, afatinib is Boehringer Ingelheim's irreversible EGFR, HER2, and HER4 inhibitor. They did a study that looked very similar to the kind of studies that started to generate information in Tarceva working in mutations and then Iressa working in mutations, where they took people who had a known mutation and compared their drug to standard first-line chemotherapy, and it was better, which is not a surprise. That's what, there's about 5 or 6 studies with Tarceva and Iressa that have shown a similar thing. What we don't know is whether the afatinib is any better than those drugs. Sure, you can show you the preclinical science that it binds tighter, that it hits some other molecules. But in a patient with an EGFR mutation, I don't know if it's any better at all. There are 2 head-to-head studies going on comparing afatinib to either Iressa or Tarceva. The one that is most interesting is going on in the Far East, and that's with people with a proven EGFR mutation, and they're going on gefitinib, so the gefitinib is Iressa, sorry, with the afatinib. And that's going to be really interesting. Are they the same? Are they different? Are they more or less toxic? There's another study which makes not very much sense, which is people who they haven't bothered to see if they have a mutation. Indeed, they're actually patients with squamous cancer who have a much lower incidence of mutation. And that, to me, is a silly study, which isn't going to give you the answer at all, because you want to know, if you know you have a mutation, you want a study that says, for people who have the same mutation I've got, which is the better drug? And that's the Far East study we have to wait and see about.
I want to add. Go ahead.
Well, it's ongoing. I suspect it'll recruit fairly quick. Maybe in about the next couple of years, we might know that answer. So that's the only drug that's currently licensed, in the process of being licensed with the FDA in lung cancer that I'm aware of. There are many other drugs in clinical trials which are looking promising. So this is a totally off the back of the cuff list, so whilst I sort of try and make it up, but to give you some examples. So crizotinib is kind of the gift that keeps on giving. So crizotinib shows some activity in ROS1, rearranged lung cancer. And because ROS1 is is a much rarer subtype, even though I suspect the results will look exactly the same as crizotinib in ALK-positive lung cancer, the question is, will the FDA say you need to show 100 patients with ROS1, or is it going to be sufficient to show here's 30 patients and look, it looks exactly the same? And that's a regulatory issue that the FDA have to sort of take home and sleep on. But I suspect expanding the license of crizotinib to include ROS1 is going to happen fairly soon. Crizotinib also works in a very rare subgroup of people who have MET not as a mechanism resistance to EGFR, but as the primary driver in their cancer. So for those of you who are negative, these are the other things that can be looked for. So MET gene amplification as a primary driver, it's probably less than 1%. There, the challenge is that's not an all or none. You don't have or don't have increases in the copy number of the MET. It's a continuous variable, and there the challenge is where do you put the cut point to make the decision, and that's another challenge for the FDA. BRAF inhibitors are a bunch of drugs that looked fantastic in people with melanoma with a specific mutation. Exactly the same drug and exactly the same mutation in colorectal cancer didn't work. So clearly having the mutation alone isn't always enough. Sometimes it's the context of the mutation. Those mutations do occur in lung cancer, so BRAF mutations, again, they're about 1 or 2%. And the studies of BRAF inhibitors in a BRAF mutant lung cancer are ongoing, and we haven't seen any public data as to whether that's going to look like the melanoma group, which means it'll be a slam dunk, or whether it's going to look like the colon group, in which case there's a lot more work to do. And then the other one that I think there's a huge amount of hype about is a totally different class of agents called immune stimulant drugs. So they have names like PD-1 or PDL-1, which stands for programmed death 1 or programmed death ligand 1. And this is a funny thing that perhaps none of us even knew about because we're not sort of hardcore immunologists. But essentially, part of your immune system's job is to go in and reject cancers. They've done studies over decades that says given the number of mutations we get every time we're exposed to passive cigarette smoke, every time we go out into ultraviolet light, every time we take some food that's not good for us, we generate mutations. Yet the rate of cancer in humans is actually much lower than you would expect when you look at the rate of mutations which occur. And one of the arguments is clearly we have mechanisms to repair mutations, but the other is we actually do have a functional immune system that's quite good at deleting very small deposits of cancer before they have a foothold. So one of the things which is kind of obvious when you think about it is when you actually get cancer, one of the things that's happened is a failure of your immune surveillance. Now, we didn't have any way to address that until very recently. But now they've recognized that in some people, you can look at molecules that the cancer express that actually reject the immune system. And these new drugs go in there and prevent that sort of rejection going on. They block that interaction. And now the immune system can come in. They don't work in everybody. This isn't a panacea any more than any of these other drugs are. They produce a response rate of about 20%. And drug companies, there's several different drug companies developing these class of agents, and they're pursuing one of two different approaches. One is, gosh, it works in 20%, we're going to be the first to market, we're going to give our drug to everybody. I think that's stupid. I think that's almost immoral, because that's back to the way we used to develop drugs. That's a marketing-driven development, it's not a scientific. The much more attractive move is to say, what do those 20% have in common, and how can we find them? And there are other people now pre-testing people for some of the markers that they think pre-select for these people. You'll always have the argument that how perfect is that marker? Are you unfortunately excluding a few people that might do it? But it's much better to have a drug out there to licensed and then gradually expand its label than have a potentially good drug not even get anywhere on the shelves because they don't get the study right in the first place. So a few molecular, I'm going to summarize what I just said. So a few key molecular indications, expanding some labels, some new labels coming out, and then a completely new class of agents, these immune stimulants. But just like everyone else, they're going to have to find the markers for who they work in.
Tell Natalie that answered her question without me having to ask it. Christy.
I've heard it's been mentioned a couple times, ERESA. And if I'm the only one in the room that doesn't know what that is, then we can talk afterwards. But could you?
No, I can tell you now. So ERESA is, so you know what Tarceva is?
Yes.
Okay, so Tarceva was developed by a combination of Roche, OSI, and Genentech. ERESA was developed by AstraZeneca. ERESA is also called gefitinib, Tarceva is also called erlotinib. They were both EGFR inhibitors, and they were going head-to-head. They were the Pepsi-Cola versus Coca-Cola in the kind of early 2000s. They both showed fantastic responses in subsets of people, but they had no idea who those people were. The EGFR mutations hadn't been described. They both did big studies mandated by the Food and Drug Administration to say, go on my tablet or go on nothing when you'd been through your initial chemotherapy. The ERESA one failed to show an improvement in survival. Even though some people clearly responded well, the average, because this was the minority, didn't shift enough to get it a license. And it lost its provisional FDA license. So it had a conditional license and it lost it. Tarceva did exactly the same study and just managed to shift the median overall survival enough to get a license. But only by a few months. I mean, not enough that would make you sit up and take notice, but enough to be statistically significant. That was why ERESA disappeared from the US market, although it actually maintained a market in the Far East. So if we were having this conversation, we were sitting in Japan, most people would be on ERESA. But now in the US, the only people who are still on ERESA is those people who were lucky enough to start it long before that happened. And so the license, when they took it away, they said, we're not going to allow more people to go on it, but if you're already on it, you can stay on it. So that's why Wells is still on it. Is that fair? That's fair. Were you on a trial when you went on it?
Absolutely. Yeah. Okay, thanks.
Is there any possibility that they might revisit, and now that the testing's so much better, that they can actually get a population that's more targeted that'll respond?
Can you repeat the question, Ross, just because she didn't have a mic? That's okay.
You mean with ERESA?
Yeah, or other drugs, even other drugs like that.
Well, I'll answer the ERESA one, and then I'll come back to the other question. So the way ERESA came back, so it's a bit like kind of the Rocky movies. He's down on the mat, and then he gets back up again. So ERESA came back because Tarceva, having got a license for everybody, you could understand that there's a certain marketing push to be resistant to saying our drug only works in a small population when you figured you were going to sell it to everybody. ERESA had nothing to lose, and they were very aggressive about honing down on this group. So the whole idea about these drugs specifically working in mutations was actually driven by ERESA, by a key study that came out in 2009 called IPAS, and the I stands for ERESA, that was done in the Far East. That was the first of these ones that said if you, well, they didn't actually pre-select, but they did it retrospectively. But if you had a mutation, that the targeted drug was better than chemotherapy in that molecularly selected population. So they then had a rearguard action, and they went from the Far East, where sort of the fires had been kept burning, and they went back into Europe, and then they got a license for just EGFR mutant disease in Europe. And then they had a long debate as to whether they should attempt to file for an EGFR mutant license in the States. But I suspect because they haven't done it, they're not going to. And I suspect with the afatinib chasing that down, they may decide not to go there. Now, your other question was, I think I'm going to try and interpret your question, so tell me if I get it wrong, or just before I start warbling on, just kind of rein me in. One of the great tragedies is when you see drugs that in the early stages of development work amazingly well in some people, but it's not enough to shift the average, and so their registration study crashes and burns and they walk away from it. And I could give you a wonderful example. There was a class of drugs which I think may have one of the best names ever, which were called death receptor agonists, which sounds like a video game. And these were drugs which, almost like the kind of immune thing, they were supposed to push suicide buttons on cancer cells. And it worked fantastic in the labs. They were developed by Genentech and Amgen and Human Genome Sciences and a few other companies. And there were some people who did really well, but when they did the study, and it was often chemotherapy plus or minus this other agent, which wasn't a tablet, it was an injection that you got, it wasn't enough to shift the average. But if you looked in many of those studies, in the arm that got the 3 drugs and not just the chemotherapy alone, there was this long tail of about 10 to 20% of people who weren't progressing. But that wasn't enough to shift the average. And it's funny because I remember contacting one of the companies saying, well, we're really interested in, finding out who these work in. Do you have any of the drug that we could have for clinical trials? And they said, well, we've only got enough that we have to stockpile for the people who are still on the drug, but we think it's a drug that's going nowhere. And you go, the fact that you have a stockpile for these people who are still on the drug, don't you think that's telling you something? So I really think, yes, if, they have those shows, where people go over cold cases, for murders. They should do that for drug development. They should find drugs that just, maybe there was a hint, maybe there was a clue in there that we could remine instead of having to reinvent the wheel.
So to go back to a couple of things for some people online. One was a question about targeted therapies, and if the patient does not, like in Lynn's case, necessarily test positive for it, will insurance still cover it? Do you know if the payer?
It's going to depend on the insurer, so it's hard to give a. Let me give you a kind of sideline example. You remember I said there was only one FDA-approved test for crizotinib? So that's this break-apart fish testing I described with the red and green dots. But there are a number of other diagnostic assays. You can do immunohistochemistry, where you stain the tumor specimen to see if it's expressing the protein. You can take some of the DNA and see if there's a little fuse bit, and that's called RT-PCR. They're not FDA-approved tests. They may be in the future, but they're currently not. Yet, no one that I know who's proven positive on these tests has had any problem getting the drug from their insurer. So even though the official label says with an FDA-approved test. So maybe some insurers are going to become really hard-nosed about it and look just exactly at the letter of the law, and others aren't.
Going back to the drugs that are on the shelves, is there, during the process, or is there a catalog that somebody could go through and try to locate certain, the drugs that are on the shelf to possibly promote development of that drug now that there's more known about these mutations?
Because Terry will go through the catalog. She will.
So we have to draw a distinction. So on the shelf, to me, means an FDA licensed thing sitting in the pharmacy. What you're saying is there stuff that have people have developed and have kind of sidelined And then there's a third category of drugs which are in development. You can find that in clinicaltrials.gov. The trouble with the other one is, the pharma industry is a for-profit industry, and they don't make these things and stick them in warehouses. They move on. They jettison the unnecessary load. There is a small exception. So the government, something called CTEP, which I'm trying to remember what it stands for, Cancer Therapeutics Evaluation Program, does sometimes adopt drugs, often from small drug companies or from drug companies that say we don't want to develop it further, and the government will take it on and pay for a certain amount to be made, and then will sponsor applications for people to do trials with these things. The question there is, how does CTEP decide, well, we're going to put that one in our catalog, but we're not interested in that one? And it's like anything else. There's a committee of people, and sometimes they make the right decision and sometimes they don't. I think what would be most interesting would if they didn't just grab kind of Me Too drugs. If there's 10 inhibitors of X out there, just saying CTEP needs one of these in their portfolio, it probably doesn't make much sense. It would be much more important to take drugs with, maybe a hint of activity that nobody else is actually taking forward from the pharmaceutical approach. So, for example, there isn't a death receptor agonist in the CTEP portfolio.
So what you're saying is during the process of developing these drugs, I would think the way that any kind of regulations is that they would have to keep some kind of log and records. They might not make them public, but they definitely possibly need to catalog them so that, there's a record of who's working on what.
Well, you raise a very important thing. So the publication of negative studies is a hot button topic, not just in the US, but in many other countries. Because sure, from the pharmaceutical perspective, they've got the data, they've looked at it, it's not working, they're moving on. But whether that information might be useful to others, I think is very real. And I think there's a big push to try and get that more public. The problem is, it's not, unless you mandate it, it's, nobody wants to be spending any time doing it if, the company's not developing it. It becomes yesterday's news. But I think there is a big push that negative studies should be published in detail. And maybe they can just be, they don't have to be fancy, they don't have to be glossy. They could just, dump the data somewhere. I don't know that that's answered your question. But what there isn't a big long list of stuff you can go look through.
Well, I would think it would be the advantage for all the pharmaceutical companies, because like you say, you don't want to reinvent the wheel. Like the software companies, if there's a software, if there's a software package out there that's going to do what you want, you go buy that package instead of putting engineering on it. So you'd think that the pharmaceutical companies, if there's things that are out there that they don't have to start, they might just be able to pick up and build on top of that. So, I think it would be beneficial for everybody.
Yeah, I can see I'll be the devil's advocate here. There's also the bit that they're always competing with other pharmaceutical companies, and they're kind of releasing some secrets, and maybe they're worried that they're going to be giving something away. I don't believe that, but that's.
Well, they could charge for it,
Okay.
They don't need to give it away, but they could charge for it.
Okay.
I got a note about getting kind of close to timeout, at least online. So there's a couple of questions from online patients that I want to get to before that happens. One, I think, is particularly important because I'm actually confused by it. But someone online wants to know what you think about treating a stage 1 patient who's ALK positive with Xalkori.
I wouldn't. Okay. And I get asked this question a fair bit, and I wouldn't for 2 reasons. First of all, you may be cured. So why do you need anything else? Right? That's the obvious question. The other is, for all of, which almost I can probably loop back into, one of the questions as to why aren't we curing people with stage 4 lung cancer? Even when, the people with EGFR mutations have these wonderful responses, and people with ALK positive disease have wonderful responses to crizotinib, even to sometimes the scans look normal, yet something always comes back. And the reality is these drugs do not produce 100% kill. They depopulate the cancer, and something remains. The cancer probably enters some kind of dormant state. A tiny proportion of the cells, probably, a fraction of 1% enters a dormant state. And it's not growing, but it's still there. And so the drug isn't going to kill that. And so with a stage 1, where the goal of treatment after the surgery is to maximize the cure rate by killing off anything left behind, these aren't going to do that. They might increase things suppressed, they may prolong the time before something pops up again, but you cannot have a defined course of treatment and then stop it, because you won't have cured them. And Dr. Neal actually did a very nice study last year that was supportive of this. So he took people with an EGFR mutation who'd had surgery, and they were allowed to go on. There was no randomization. They all got Tarceva for about 2 years. Now, the initial take-home message was that 2 years, 98% of people had no evidence of the cancer coming back. These were early-stage cancers that could have been cured by the surgery alone. And they all stopped the Tarceva at 2 years. But at 3 years, that rate was about 60%, and at 4 years, it was about 40%. So the takeaway message is, sure, there's probably a group of people who are cured who didn't need the Tarceva in the first place. There's a group of people who weren't cured, and all you've done is you've kept the lid on it, and as soon as you stop it, it pops back up again. So we probably need better tools to decide who actually is or isn't cured and probably needs this ongoing suppression. But I think for somebody with a 1A, if they say, oh, you're going to go on, crizotinib for 1 year, I don't think that makes any sense.
Okay. Another question back to the immunotherapy. Is there anything out there right now for lung?
There's license, no.
Mm-hmm.
So the successes in immunotherapy, and we've known this for a long time. So the idea of your immune system actually being functional, the two standout cases are melanoma and kidney cancer. And if you go back to ancient oncology textbooks, there you can see these wonderful pictures. So as some of you may know, when you get pregnant, your immune system gets altered. And there's a wonderful picture of a woman who I think had kidney cancer. And every time she wasn't pregnant, her cancer would get worse. And every time she got pregnant, her cancer would get better. So she's lined up with about 9 kids because she just kept getting pregnant to keep the cancer under control. And what they showed is, obviously there's the vaccine for cervical cancer, which is really an antiviral thing, which is preventing you getting the cancer in the first place, which is a kind of different thing. But in melanoma, there's a class of agents called CTLA-4 antagonists, of which one of the drug names is called ipilimumab. And that, again, is another brake on the immune system. You take the brake off and you can unleash this, and some people's melanomas will get better. The obvious side effects are you unleash your immune system and you start to reject bits of yourself. And they often get something that looks a bit like ulcerative colitis, which is an autoimmune condition. Sometimes they can get inflammation in the lungs. So in lung, the CTLA-4 antagonists are still being explored, but haven't looked as exciting as they do in melanoma. The PD-1, PD-L1 are looking more exciting. And then there's some vaccine studies that are ongoing and some vaccine studies which have recently read out. So there's 3 big vaccine studies. So one was called Stimuvax, which was given for people who had stage 3 cancer. That's when it spread to the lymph nodes. They had chemotherapy and radiotherapy together, and then they either got the vaccine or they didn't. Again, people who might have been cured, was the vaccine going to increase the cure rate? And unfortunately, we heard a few weeks ago that was a negative study. So clearly just giving this vaccine to everybody wasn't enough to shift that average. We haven't seen the details. Maybe there's a subgroup, but we don't yet know. And then there's 2 other vaccines. One is called the Camidge vaccine, which again was for people who this time had surgery, so early stage cancers cut out, and they were randomized to get this vaccine or not. That is arguably the biggest study ever done in lung cancer. So it was over 1,000 patients, and we'll probably see the readout in a few years' time. And then the other is a small company called Lucanix, who went perhaps the hardest pathway, which is to have a vaccine that was going to affect people with advanced stage cancer. So the cancer's still there. There's lots more of it compared to these other things. And they had a promising but relatively small phase 2 study that showed their vaccine worked, and that justified a big phase 3 study. But we have seen no data at all. And so, until we see that data, we don't know if that's going to be Stimuvax or a success story.
One other question that I absolutely have to ask, we've talked a lot about targeted therapies and molecular profiling for non-small cell lung cancer patients, but for the squamous cell, the small cell, the carcinoids, the mesos, all the other guys out there, what are they looking at? I mean, are things, A, is there anything available? And B, is there anything in the pipeline, I guess?
So the short answer for small cell and mesothelioma, nothing at present. There are some, for small cell, there were some studies published from a couple of different groups where they took a bunch of people with small cell and they looked in great detail at every aspect of the genome of the cancer. And they could see a long laundry list of things that may potentially be drug targets. But what the take-home message was that, if we think adenocarcinoma is looking complex with those slices of the pie, small cell's even more complex. Each slice of the pie was very, very fine, to the point where these two series that were both looking at, somewhere between 20 and 50 small cell lung cancers each, had almost no overlap between the two series. So it's almost like every small cell is a completely different disease. For squamous cancers, that is probably going to be the next big breakthrough. We can clearly see some potential drivers in small cell, although there's still a big unknown slice of the pie. FGFR, fibroblast growth factor receptor, gene amplification, may be, so that's increases in the copy of a gene instead of just two, one from your mom and one from your dad, may predict for sensitivity to things called FGFR inhibitors. The big issue is what is the true proportion of that? It's a continuous variable, so where do you put the cut point? It may vary geographically. It may have a higher incidence in Europe than it does here, and that may depend, because squamous is more smoking related. It depends on what was in your cigarettes. And then there's a few other slices of the pie in squamous. So it's kind of all to play for in squamous, and I think in the next couple of years, we're going to start to see some breakthroughs there. And also, I'm really optimistic that this unknown slice of the pie, people are going to try and hone down on by saying, okay, we have some other things which aren't just looking for mutations and rearrangements. We are starting to look at, levels of receptor, levels of growth factor, and, maybe that will start to identify other trials we can do. So
to kind of go back to really quick to those outside of the non-small cell category, is there such a thing as someone having, I know there's like an adeno, maybe squamous mix, right? So what does that mean in terms of molecular testing for that person?
Well, that's where you need a good molecular pathologist who may well choose to dissect out the squamous region, test that, dissect out the adeno region, and test that. It almost goes back to when we said, what happens if you have, two mutations? What does this mean? They're probably in different populations in the cell. Sometimes you don't have to combine both drugs together. I saw a lady 2 weeks ago, never smoker, who from the bat was told that she had a clear ALK rearrangement and an exon 19 EGFR mutation. Okay, and we had the debate as to, do we give her one drug, do we give her both drugs? And I started her off on Tarceva. And I started her off on Tarceva for two reasons. One is she was more likely to have a false positive ALK test than a false positive EGFR mutation test for various technical reasons, and we're rechecking it in our lab because they were done in an outside lab. The second reason is there's a few case reports out there with people responding to just one drug, because again, if they're different populations, again, if we draw a line down the middle of the room and you're EGFR mutant and you're ALK positive, I can still get half the cancer to shrink by giving just one drug. And that may be beneficial. Mm-hmm. So she could have and because the tests are absolute, they don't tell you proportions, I don't know whether she's, 90% one or 10% the other. So I'd start with one drug rather than giving her lots of side effects and see how we go.
And that would go same for like BAC, like in...
Yeah.
Okay.
You had a question?
Is it customary now, or are they starting to give you drugs or chemotherapy or something after surgery when you have stage 1 and they remove the top lobe and the center lobe, let's say, because the center lobe sometimes is so small that you can't save it. It's part of the top lobe. So is it advisable now to give chemotherapy or radiation or anything after or before you do that? Or you just do the surgery and that's it?
So for stage 1 cancer, so that's a cancer that's in the lung that hasn't spread anywhere.
Right. Nowhere.
Then The official line is these people usually do not need extra treatment. Their chances of cure are sufficiently high that the extra toxicity and the side effects from giving a course of chemotherapy isn't needed. There's one exception, which is when the cancer is very big. A small kind of retrospective analysis suggested that they may be sufficiently high risk that they may nudge into it. So most people would agree for stage 2 upwards. So stage 2 is when it's spread to the lymph nodes within the lung. And then if it's a big stage 1, then you'd certainly have the debate. Because the data is a bit more shaky, it's more of a discussion rather than an absolute recommendation. But if you had a small stage 1, I would, quit while you're ahead and wouldn't do anything else.
Then if you end up with a lot of other spots, like a ground glass on one side and all that stuff.
That would make me less inclined to give it because you probably have a multifocal process.
2 years later, 3 years later.
Oh, they come up 2 or 3 years later?
3 years later. But nothing big enough to biopsy.
Yeah. So what you're talking about, so BHD, as you know, stands for bronchoalveolar carcinoma, which is a terrible mouthful, but that's perceived to be, for many people, a precancerous condition. And they've actually, so what it is it's changes in the cells inside the lung, and initially they just line the airway. So they don't break down the airway, they don't start to invade and go to other places. And that often looks like this thing called ground glass on chest x-rays. So it's not a solid lump, it's looking like your frosted shower door. And that, when you biopsy it, if you don't see any invasion, it's now actually called adenocarcinoma in situ. So if you know anything about how cervical cancer is staged, there's a pre-cancer in the cervix, which is called CIN, which stands for cervical intraepithelial neoplasia, but essentially carcinoma in situ. So that means it hasn't invaded. Most people now wouldn't treat that. I think we would just observe that. And what we do is we look, because it's often in lots of places, we look for when an area starts to change. So you have to imagine now your lungs are all at risk of developing cancer because they have this going on, but not everything has become a cancer. So you watch somebody pretty closely, and then if one area starts to become denser, starts to look like it's taken that extra step to become a cancer, sometimes you'll cut that area out or zap it. And so it becomes more of an aspect of constantly weeding the garden.
Yeah. So that's what they're doing.
Yeah.
Yeah.
So I know I just want to stop right here just for a second. We can take a couple more questions, but I want to make sure to get out my thank yous to everybody before the live stream goes out. Thank you, obviously, to Genentech for sponsoring this and making this possible. Once again, to Penn TV and crew for helping us get it out to all of you at home so that you are able to hear Ross and get some of your questions answered. If I was handed a question online that you asked and it was not answered, please email me and I will get the answers for you. Much thanks to some of our visitors in the room. We have visitors from Sanovis and Mauna Kea, and I don't know if anybody from Genentech wound up coming. I think they wanted to come and kind of hear what was happening, but many thanks to all of you for coming tonight and for making this possible.